All right, well, I admit to a poor wardrobe choice. I went back to my room to change at lunch and I had forgotten that the background was blue. So I hope I'm not disappearing and fading in. What an honor, what a true honor it is to share this stage with so many esteemed speakers this weekend. So thank you to Jeff Gerber. All right, I think all the disclosures were on the website, so I'm going to skip that. I am so glad that I'm following Dr. Tro, because Tro really emphasized how wrong some of the conventions are in a lot of what we do. And this could not be more true in thyroid. So I have a short slot to speak today, but in the time allotted, I hope to not necessarily completely change your clinical practices overnight, but I hope to at least plant a seed. I hope to get a lot of you thinking that maybe the way that we've been detecting, diagnosing, and treating hypothyroidism needs to change, if not be radically overhauled. So I ask that you come with an open mind, because some of what I'm going to say is controversial and unconventional, but if there was ever a perfect audience to say something controversial and unconventional, it's a group of low-carb proponents. Because in the outside rest of the world, low-carb and ketogenic diets are still controversial and unconventional, right? So just keep an open mind. So why do we need to talk about thyroid at a low-carb conference? Some of you, and if I use the shorthand doctor, please know I am using the phrase doctor to refer to anyone, any medical professional with test ordering or prescribing capability. So all of you physicians, nurse practitioners, PAs, all of you. So what about the patient who's doing everything right? The labs look great, the A1C, the glucose, the triglycerides, everything looks right. They have the blood work of someone who is absolutely sticking to a low-carb or ketogenic diet. But the weight won't budge. By all accounts, this person is very healthy, and yet they're carrying excess weight. Maybe their cholesterol is a little high, so maybe they're taking a statin. Maybe they're also taking an antidepressant. The patient probably feels frustrated, demoralized, disappointed, maybe even a little angry. You know, doc, I am eating less and exercising more, and I can't lose this weight. You keep telling me I'm so healthy, but why can't I lose this weight? We have to be able to help these people. So what do thyroid hormones have to do with fat loss anyway? Most of us learned somewhere along the way that thyroid hormones are the master regulator of the metabolic rate. If you have low thyroid, it can be very difficult to lose weight, even with a good diet and exercise, even a good low-carb or ketogenic diet. I'm sure some of you have seen patients or clients like this. It is not uncommon to have undiagnosed hypothyroidism for years and sometimes decades. These patients may have even been accused of lying about their diet and exercise. Well, you must not be following the diet, because if you were, you'd be losing weight, right? So they call this medical gaslighting. You cannot out keto a major hormone imbalance. So if someone has a thyroid problem, keto, I think we can all agree, and we've seen already just in this one day of talk so far, keto is darn near miraculous. It does a whole lot. You can lose weight eating anything. Not every way of eating prevents seizures. Not every way of eating puts bipolar and schizophrenia into remission, as we've seen earlier today. So keto doesn't always fix thyroid conditions, but it can help sometimes, and we'll get to that later. Signs and symptoms of low thyroid. These are only the most common classical ones. This list could go on and on and on. Because of the role of thyroid hormones, there's really no organ, gland, or tissue that is not affected by low thyroid hormones. The most classical ones: weight gain or difficulty losing weight even on keto, depression, constipation, hair loss, feeling cold, high cholesterol. I could go on and on. Let's blow through the thyroid hormones so we can get to the real meaty stuff. There's a hormone called thyrotropin-releasing hormone that comes from your hypothalamus and tells the pituitary gland to secrete TSH, thyroid-stimulating hormone. TSH, again, it's produced in the pituitary gland, and it tells the thyroid to produce hormones. Hey, knock, knock, hey, thyroid, go ahead and make some hormone. The thing to know is that I say neither of these, but most importantly, TSH, is not produced or secreted by the thyroid gland. It's a pituitary hormone, and it does not always reflect the level of actual circulating thyroid hormone. I know most of you were taught that it does. It doesn't always. Next up, the largest hormone, in the greatest quantity that the thyroid produces is the T4, right? And thyroxine, measured as total and free. T4 is an inactive hormone, and we're going to come back to the importance of that in a little bit. It is inactive. It does not have the biological, cellular, metabolic rate supporting activity that we associate with thyroid hormone. The one that does that is T3, the triiodothyronine. This is the active form of thyroid hormone. Oh, I should go back a minute. Other tissues convert T4 into T3. The thyroid gland produces much, much more T4 than T3, but it does produce a tiny little bit of T3. And most of the T3 in your body comes from converting T4 in the other tissues, but the thyroid gland itself does convert a little bit. So anyone who's had their thyroid gland removed or irradiated is going to lose whatever small amount of conversion happens in the actual gland. If you see someone whose TSH is normal, but you suspect low thyroid based on the symptoms, it is critical to measure the T3, specifically the free T3. That is the hormone that's responsible, again, for those cellular effects, not TSH. There is reverse T3. Think of reverse T3 like a T3 imposter. It kind of fits in the cellular receptor for the T3, but it doesn't do anything. It doesn't have the same effect. The effect it does have is that it blocks the real T3 from getting through. It blocks the action of the T3 that we want getting into the cell. It can be increased for a number of reasons. I said this was going to be controversial. It's really controversial among some people whether you should ever test reverse T3. I think you should when everything else looks normal, but the patient or client sitting in front of you is wicked with symptoms, signs and symptoms screaming out of their paperwork and their blood work. I do think you should measure the reverse T3. Now, if the reverse T3 is elevated, but the regular T3 is normal, that could lead to somebody being symptomatic, because even though there's enough T3 in the blood, if there's too much reverse T3, the T3 isn't getting into the cells, which is where it needs to be. T3 does no good hanging out in your bloodstream. It has to get into the cells. The antibodies, real quick, we know this is how you would detect Hashimoto's or Graves', the thyroid-related antibodies. The number one thing I want to emphasize to you in this talk is that TSH is not always sufficient to identify hypothyroidism. I know it is the gold standard. I know it's what you were taught. It is not sufficient in all cases. Sometimes it is. And again, real quick, if somebody doesn't have signs or symptoms of hypothyroidism, none of this is relevant. You don't need to do any advanced testing if nobody's complaining of any signs or symptoms, right? So I'm talking about a subset of people. I'm going to show you one example of a client that I worked with who fell into this exact situation. This was somebody who had been following a low-carb diet for many years. She was maintaining a weight she was happy with. Her health was excellent. She was not on thyroid medicine at this time. Again, like I said, metabolically, I mean, this is a limited look, but this looks very good. This looks like the blood work of someone who's adhering to keto. A1C, perfectly good, low trigs, high HDL. That total cholesterol is a little high and the LDL is a little high. Now, I'm not a cardiologist, but to me, this doesn't necessarily mean cardiovascular risk. Combined with the signs and symptoms you're about to see, to me, what this was another sign of potential hypothyroidism. Her TSH was normal. If anything, it's at the low end of normal, which you might suspect more of a hyperthyroid situation. So her TSH was normal, the T4 was low, and the T3 was low. If you only ever measure TSH, you're not going to see that remember, TSH, not a thyroid hormone. It's a pituitary hormone, and what did I say? It does not always respond properly to the amount of actual circulating thyroid hormone. So if you only test the TSH, we have no explanation for why this poor woman had extreme depression, hair loss, fatigue, severe constipation, and the elevated cholesterol. And despite following the low-carb keto diet she had habitually followed for years with regular exercise, she had gained weight inexplicably. Then she sees a doctor who knows what they're doing, following the same habitual low-carb diet, same regular exercise. Now she's taking a combination thyroid medicine, T4 and T3. Now the TSH is low. It's actually suppressed to almost unmeasurable. We'll get to that in a minute. But the T4 is normal, and the T3 is now normal. And her symptoms were gone within weeks. She lost that excess inexplicable weight rapidly. A1C is still good, trig still low, HDL still high. Her total cholesterol has come down 80 points. She was still following the same keto diet, same amount of exercise. The difference is the thyroid medicine. So again, is this improved cardiovascular health? I don't know, I'm not a cardiologist, but I can say the hypothyroidism has been corrected. And her TSH was so low, almost unmeasurable, but she had no signs or symptoms of hyperthyroidism, right? How is hyper typically diagnosed? Very, very low TSH. She had no signs or symptoms of hyper. So Antonio Bianco is a former president of the American Thyroid Association, and he published a book, couldn't have been better timing, just came out last year, Rethinking Hypothyroidism. Treatment of hypothyroidism is not as simple as we patients or physicians have been told. Many more things need to be considered in addition to circulating TSH. Thank you, Dr. Bianco. My thanks to R.D. Dykman from the type 1 diabetes world for bringing this juicy morsel to my attention. Dr. Bernstein, anybody know Dr. Bernstein in this room? Yeah. Serum TSH does not reflect T3 levels throughout the body. It is not a good marker for hypothyroidism. Serum-free T3 is the best indicator of thyroid status. I would go one step further and say symptoms are the best indicator of thyroid status, but I'll take serum T3 as a backup. The standard of care is wrong, and hypothyroidism is grossly mistreated. Is it possible that the conventions are wrong, like they are for obesity and like they are for diabetes? Do we need a revolution in thyroid? Why are we following a test that has no correlation to clinical presentation? Thyroidologists have decided that this is the best, when in fact it is unrelated to how the patient feels. The consequences of this have been horrendous. TSH needs to be scrapped. Medical students need to be taught again how to clinically recognize low thyroid. What is clinically recognized? Signs and symptoms. All right, so if somebody's TSH is normal, but they're screaming off the chart with signs and symptoms, what are we going to do? I implore you, I encourage you, I recommend you with all my heart to order a comprehensive thyroid panel. So that's going to include all those other hormones. We're going to do not just TSH, we're going to do the T4, the T3, most especially the free T3 and the reverse T3. You could throw in the antibodies if you suspect an autoimmune problem. So you want to order, if the TSH and T4 are normal, doing the comprehensive panel might identify those other hormones that are low that are causing the symptoms. I see this all the time with people who can't lose weight on low carb or keto. Now, fully admit, I have a biased population sample, right? Because who's coming to someone like me for help? Someone for whom the average sort of garden variety keto diet isn't working. And after we kind of rule out all the other possibilities, are they eating too much carbohydrate? Are they eating too much fat? Are they on medications that are causing difficulty losing weight? Once all that's been resolved or figured out, we have to look at thyroid. Some of them already know they have a thyroid problem, but maybe they're not on the right medicine. We'll get to that. So I see this all the time. So I'm just, in the US, in most states, people can order their own blood work. Whether or not you think that's wise, it's possible for them to do. So anyone, if you are a patient out there, then that is available to you in most states. Even if you do order a comprehensive panel, though, there are problems if somebody is normal. I say that the normal lab values for thyroid hormones are a hodgepodge. That's putting it nicely. Let's look at this TSH as one example. Normal TSH from 0.5 to 5.0. That is a 10 times difference. So my TSH could be one level, your TSH could be 10 times higher, and we are both considered normal. Same thing with the T4 and the T3. Look at the free T3, or the total T3 from 60 to 180. We're talking about a tripling. Your TSH could be one level, your T3 could be one level, her T3 could be triple, 3 times as high, and you're both normal. I think in the keto world especially, we can agree that normal does not mean optimal. What does normal mean? I think an example I can share with you from the low-carb keto world is that a lot of labs will tell you that a fasting insulin of 20 is normal. Well, that may be normal, but I wouldn't be happy with, most of us wouldn't be happy with that for ourselves or our clients and patients. But it's normal. So what happens with normal, with thyroid? How someone feels is more important than the numbers on a lab test. I am not suggesting that you ignore the labs. Do the labs, absolutely. But also consider the living, breathing human in front of you. If you run a comprehensive panel and everything's normal, but again, the person in front of you has unmistakable signs and symptoms, how can we say they're normal? So if that's a situation you've come across, or you will in the future, consider the shortcomings of those normal ranges. Normal does not mean optimal. And remember, especially with T3, T3 does no good swimming in the blood. It has to get into the cells. And the level in the blood doesn't tell us how much is getting in. We don't have an easy way to measure that, so the blood T3 is really just a proxy. It's a second best. What tells us how much is getting in are the symptoms. This is a consensus statement from not one, not two, but 3 thyroid associations. Serum thyroid hormone levels are only a surrogate marker and may not reflect what's taking place inside the cells. Again, what tells us what's actually happening at the cellular level are the symptoms. Anyone know Penny Fig Tree? I don't see any hands. She's oh, there you go. She's an MD in Australia. I think she's spoken for low carb down under sometimes. This is a personal communication. I have been a hardcore TSH only doctor my whole life. Never had a clue about the other tests. I'm really wanting to understand it now. As you know, low carb doctors want to know more and are not blind followers of the textbook they were taught. I am now much more open to how terrible this condition is and how important it is to treat the symptoms, not the blood test. What about thyroid medication? Let's say you identify a problem, this person needs medicine, what are we going to do? The most commonly prescribed, this is sort of the gold standard of care for hypothyroidism, is the T4, the levothyroxine. In the US, the most common brand is Synthroid. We've got the synthetic T3, the liothyronine, common brand name Cytomel. Then we've got the natural desiccated thyroid, the pig thyroid gland. That gives you T4 and a little bit of T3 and some related compounds. There's no right or wrong, there's no good or bad. Natural is not necessarily better than synthetic. What matters is what works best for the patient, and it really is a very individualized thing. Problems with the testing, problems with the normal ranges. We've got big problems with levothyroxine, or I could have said problem, it's really only one problem, singular. And that is that levothyroxine is T4 only. T4 is the inactive hormone. It has to be converted into T3, and in a lot of people, this does not happen optimally. Up to 20% of people who take levothyroxine don't convert well. So 20%, 1 in 5. 1 in 5 people is not going to do well on levothyroxine. There's polymorphisms in the enzymes that do the conversion. There's other factors that can contribute. If you give a medication that's only T4, okay, so it is problems, plural then, I take that back. If you just give T4, it's possible that that T4 could be converted into reverse T3, which is going to exacerbate the signs and symptoms of hypothyroidism, because now we've got even more of that reverse T3 blocking the T3 that we want from coming into the cells. And if somebody is taking levothyroxine, even doses 100, 150, 200 micrograms a day, and they still feel terrible, they still have all the same signs and symptoms, it might be because the T3 is low, but you won't know if you don't measure it. A big thing that comes up in the medical world with using high doses of thyroid medicine is that the TSH will be suppressed. Like we saw that with that client example I showed you. Her TSH had become almost unmeasurable. But she had no signs or symptoms. So did she have hyperthyroidism? Was that like a medically induced hyperthyroidism? No. She was completely asymptomatic. So some patients are going to feel best on doses that are so high that they suppress it to almost unmeasurable. But again, is this a problem? If not only did she not have hyperthyroidism, she felt better than she had felt in years. There are concerns about atrial fibrillation and osteoporosis on high-dose thyroid medicine when that TSH is suppressed. The literature that I have seen indicates that not only is this fairly rare, and these concerns are largely unwarranted, they are almost exclusively happening in people with pre-existing risk factors. And all I'm going to say is that if somebody does become over-medicated, the signs and symptoms of over-medication with thyroid are pretty hard to deny. They're pretty easy to identify, and it's easy enough to back the dose down. That's what you would do with any other medication. And I don't know why we seem to accept a risk profile and a safety profile of so many other medicines that are routinely prescribed like candy, and we are unwilling to accept a much lower risk with thyroid medicine, and we are leaving people to suffer because we're saying if your TSH is suppressed, then you're fine when they don't feel fine. So the reference ranges for thyroid hormones in people receiving thyroid replacement are considerably different from the conventional ranges. My friend and co-author, Dr. Eric Westman, has proposed that maybe we need a keto normal. Maybe there are certain lab tests whose parameters are not the same in someone on a very low carb keto diet as they are for somebody on a diet of 50% or more carbohydrate. Do we need a keto normal? Maybe we need a thyroid medicine normal. Maybe if somebody is taking exogenous thyroid hormones, some of those lab ranges, particularly TSH, no longer apply. I'm just speculating. As long as we're talking about medication, what is the #1 most prescribed drug in the US? Millions and millions of prescriptions. Anyone want to take a guess? Good guess. It's atorvastatin. And there's 2 other statins pretty up high, most prescribed drugs. Antidepressants are also very widely prescribed. Data from 2019, we've got 7 different kinds of antidepressants in the top 50 most prescribed drugs. There's a handful of them. Okay, stay with me here. We've got millions of people on statins. We've got millions of people on antidepressants. Who wants to guess what #2 is? #2 most commonly prescribed drug. It's levothyroxine. How many people are taking a statin and taking antidepressants to treat the signs and symptoms of the actual underlying problem, which is hypothyroidism? And the hypothyroidism is either being ignored or it's being treated inadequately. So now they're taking all these other drugs. Normal TSH values may not rule out patients that are hypothyroid. It is possible that a large number of hypothyroid patients are missed using TSH as the screening tool, which is a problem for the patient who remains hypothyroid and to the healthcare system as a whole. You bet it's a problem for the patient because they're being told, your thyroid's normal, it's not your thyroid. I don't know why you have these 17 symptoms. And it's a problem for their loved ones. It's how many relationships have ended? How many careers have ended? How many children are being robbed of having a vibrant, lively, engaged parent? How much is society losing by being robbed of a vibrant, engaged citizenry? This hypothyroidism can be absolutely debilitating. And of course it's a burden on the healthcare system as a whole. What did we just say? How many millions of people potentially are taking multiple medications because the actual underlying problem is being ignored or improperly treated? And they're taking medications to treat the side effects of those. They're calling the doctor more, they're visiting you more. It's a burden on the whole system. I don't have time to go through these numbers. I just want to point out that there is a rationale for using high dose of T3, and one example is in psychiatry, and my thanks to Dr. Palmer. How about Dr. Palmer's talk? Oh my goodness. High doses of T3 have been used in psychiatry safely for years. And so as high as 86 and 93 micrograms of T3, there's endocrinologists out there right now who are cringing in their chairs. As high as 160 micrograms of T3 per day can be used. All right, close out by talking about the effect of low-carb diets on thyroid status. Some people who come to you with a thyroid problem actually get better from a low-carb or keto diet. They can start reducing their medication and eventually eliminate it altogether, right? Some of you have probably had patients like this. I don't know that there's a whole lot, if any, published research on this, but anecdotally, this seems to be more common in people with Hashimoto's, with the autoimmune hypothyroid. So it's not true that if someone is on thyroid medicine, they're going to need to take it for the rest of their life. Some people can stop it. The exception, of course, is removal or irradiation of the gland, where you will need replacement for life. Now, there's a lot of buzz on that scary, dark, dirty place called the internet about keto diets and thyroid function. Keto kills your thyroid. Women shouldn't do keto because your thyroid. Well, let me see. When you radically change your diet, your hormone levels might change. Oh, I'm shocked. This is my surprised face. Your hormone levels might change when you make a radical change to your diet and lifestyle. Who knew? So it is true that some people, not all, some, if not many people, have a decrease in T3 when they do a keto diet. Does this matter? If your T3 is lower but you feel well, maybe you even feel better than you felt in 20 or 30 years, do you have hypothyroidism? We don't need to treat a problem that isn't there. Who cares if the T3 goes down if somebody feels great and has no signs or symptoms of low thyroid? I think that this is speculation, but it's educated speculation. There may be increased sensitivity to T3, that the way a ketogenic diet changes your metabolism may make it so that you require less T3 to have the same metabolic effect, that same metabolism boosting, fat burning effect. So you might need less to have that same. My thanks to the great Stephen Finney. He wrote an article for the Virta Health blog a couple of years ago that I have sent to countless people. How many published studies from well-designed prospective human trials have shown that impaired thyroid function occurs on keto? The answer to this is quick and simple. None. Now, somebody asked me earlier if I have some thoughts on keto and thyroid. I do, but it is some people do end up with low thyroid after keto, but I don't think that is keto per se. No time for that today. I will sum it up by saying I think some of these people are chronically under-eating and over-exercising. It's not a low carbohydrate diet that's doing it. They are simply inadvertently starving themselves, but don't have time to get into that. I will sum up. TSH is not always the best indicator of thyroid hormone status. Please stop only testing TSH if it's normal and someone is wildly symptomatic. The normal ranges may leave many people undiagnosed or undertreated, and they're suffering. We talk about the dangers and risks of over-medicating. We don't talk enough about the dangers and risks of under-medicating somebody with hypothyroidism and leaving them depressed and constipated and going bald and having no libido and all the other terrible things that come with this condition. Levothyroxine is not always sufficient. Sometimes it is. Plenty of people do great on T4-only meds. A lot of people need additional T3 to feel their best. Not only do they need T3, sometimes they need high doses, doses high enough to completely suppress that TSH into the floor. Suppressed TSH doesn't automatically indicate hyperthyroidism. Your patients need you. These people are suffering, and they're suffering because, like Dr. Tro said, a lot of the conventions that we have been going by are wrong. They're failing the patients, they're failing us. When we have no better answers for some, well, your TSH is normal, I don't know what's wrong with you, you must be depressed, and here's your statin, honey, run along. Some of you know Carol Roseschmidt from the Obesity Medicine Association. She's my co-author on a book we are writing together. We will never argue for the dominance of a lab test when signs and symptoms are available. Thank you so much for letting me share some thyroid with you.